Way, wait,
The first thing we're going to look at is something that all of you kind of alluded to, which is that churches still aren't closing. We still have churches that do not close. And we still have another issue that's going on, which is conspiracy theories and lack of information about what this virus is all about. And almost, I mean, you know, this is why she is the medical director, perfectly on time, right in the moment that we want her to talk.
I'm about to run out of time because I have to do a clinical policy meeting.
Okay, well, right on time. Tammy, why don't you introduce these folks?
Thank you for joining us, Dr. Ayana Bennett, Medical Director of the Office of Health Equity of the San Francisco Department of Public Health, and also Dr. Vincent Fuqua, who is the Program Coordinator for the San Francisco Department of Public Health.
Okay.
Thank you for joining us.
So in this engagement, at the moment, I am Deputy Incident Commander for the department, and then I'll be Incident Commander next week. So that's a different role than my normal role. So I am doing this in both roles. So it's a little bit of each. So the question is just generally, what are we saying coronavirus is, right? And then what does it do and why do we care? Pretty cool, pretty good? Yeah. You are on,
yeah, they're on mute.
You're on mute, Floyd. He's talking to me though, I can tell.
He said yes.
Okay. So,
I'm sorry. And why are we social distancing? Because
yes,
there is
why are we social distancing
in the rural context. Okay.
I will add that. So, coronavirus is it's really a family because there are multiple different kinds. The coronavirus is one that is commonly reservoired in animals. That means that's where it lives, and then every once in a while it bounces to humans. So there are different ones for different animals. The DNA of this one matches some of the ones that live in particular animals and not others. So they have some guesses, but the way these work is they jump from animals to people, meaning some person had contact with an animal that had a coronavirus that had mutated enough to survive in a person when previously they did not. They mutate slowly, this kind. It's not like the flu, which goes through massive rearrangements and is really a different virus in some ways every year. That's why we need a vaccine every year. Coronavirus is more stable than that, but it does change. And the change that it made sometime probably in October or November is it made enough of a change to get into humans. What it does once it's there and it comes on the breath, it's in the little droplets of water that people put out when they speak, because everybody spits a little bit, cough, sneeze, and they even think sing. So when you put out little droplets of air, sometimes big droplets from a cough or even little ones from blowing, those droplets have virus in them if you are infected. At the beginning of your infection, you may not have enough to really pass it to anybody. You don't have symptoms. And then as it slowly rises and replicates and you have more of it in your body, you have enough to pass it to people. That may still be before you have symptoms. Eventually you get symptoms, mild, maybe even unnoticeable or quite severe, and then it passes. The symptoms come from where it chooses to live. It lives all along the respiratory tract. So it lives in your nose, in your throat, in your lungs, and all through the bottom of the lungs. So where the lung tries to get air in, the coronavirus is filling that space with inflammation, which means there's fluid there and inflammation there, and air can't get through. So eventually people have lungs full of fluid that won't exchange air, and they essentially suffocate. Their oxygen goes down and down and down. There does seem to be some organ infection as well. So there are probably some direct heart infection. They have found it in the brain on rare occasions. They know people have multi-organ failure. So is that from the oxygen? Is it from the direct coronavirus? But it seems to be very extensive, even more so than the flu in many ways. So the flu hospitalizes a portion of the people who get it. If you didn't get a vaccine, you get the flu, you get a lung infection. The flu usually you get a different kind of lung infection, but some of those people get hospitalized and a small number get ICU. In coronavirus, it is so aggressive to the lungs that many more people get hospitalized than would with a flu, and many more of those people end up in the ICU, and as a result, many more people die. So if you had 100 unvaccinated people, if you have 100 people with the flu, the chances of one of them dying is less than 1. If you have coronavirus, it's anywhere from 1 to 3 to 12, depending on what country we're talking about. So that's why we care, because we don't have any immunity to it. It's brand new. Nobody has antibodies. Lots of people have some immunity to the flu. They've gotten it at some point, but nobody has anything for this. So you are completely undefended, and our bodies seem not to be able to fight it off very well. So people always differ. So there are 80-year-olds who will get through it just fine, and there are 20-year-olds who are going to die. And that's just, everybody's different. People vary. Your lungs are different amounts of health, whether you know it or not. It's not about whether you ran marathons, because marathoners have succumbed to. It's probably physiology. Whether you smoke might have an effect. We know how strong your underlying body is in terms of your heart strength, because people with cardiovascular disease or hypertension seem to die more often. They even die more often than the 70-year-olds. So it does matter how healthy you are. And we know that we have disparities in heart health, right? So any group that has a lot of poor heart health is going to have a lot more deaths, not necessarily more infections. But when people do get infected, it's going to be more severe and they're more likely to die. So that is a group, hello group, that needs to be even more careful about not getting infected, because infection's worse. So everybody else may not social distance, be far enough away that somebody's droplets can't reach you. Because if you're close enough, you can't see the droplets, but they are landing on you. And then you touch your face where it landed, and you touch your eye, and now it's in your body, or you're eating with the hands you touched it with, and now it's in your mouth. So that's why you're social distancing, so nobody's breath touches you, which is why if they're wearing a mask, they've made you safer. They haven't made themselves that much safer, because the droplets can be anywhere. They can be on your eyes, they can be on your face, and eventually you'll make it to your mouth. But you have made them safer by wearing a mask. They have made you safer by wearing a mask. So my mask protects you, your mask protects me. The only masks that protect you are the big N95 ones they have in the hospital, and even those don't do any good unless you're also wearing goggles and a gown and a face shield. So that is the point. Go ahead. I got time for one.
I know one question. Okay. So the question that I'm having is that there are these super spreading things that happen when churches meet together. Is there something about the church community putting in churches that makes it even more dangerous than like a normal setting?
Yes. So we think there are 2 things that make it more dangerous. One, talking and even more singing make droplets go further. So there was a very bad super spreader event where a choir in Ohio decided to practice anyway. 60 people came, 40 of them got COVID because they sang all over each other. The other is that there's a density effect. So you have to get a certain amount of virus. It's like a dose of a poison, right? You get a teeny bit and it may not make you sick. So it's one person in a big room. Even if they get close to you, it may not be enough, but you get 100 people in a room, and now you've got so many more chances and so much more potential virus on you that your chances of getting sick are much greater. So everyone's had, instead of 1 dose to maybe 3 of the people in the room, you've had 6 doses to 50 people in the room. So more people have a higher dose and get sicker. So that's why those are super spreader events, because people are putting droplets out more than they normally would, because they're blasting and talking and laughing and singing. And because the density is, there are so many people close that if you had 2 people in there, they've contacted dozens of people instead of, a small room where 1 person might have contact with 2 people. Now 1 person has had contact with 50 people. We shake hands, we say, bless the, Church is an intimate thing.
I do see Peter has the quick question. Do people who get well from COVID have immunity?
We believe they have immunity to the degree that it has not mutated much so far. So it is possible, even though it doesn't seem to be a quick mutator, that at some point it'll mutate enough that you're not fully immune. You'll probably still be partially immune. The reason the flu doesn't work is it totally reorganizes its DNA, and very few other viruses do that, and this one does not. So it will drift at some point, so probably, but it may be more like a booster in a vaccine case where, you know, you're immune but not forever, rather than it just doesn't work at all anymore.
How many mutations are there?
It's subtle and there are tons of them, but I gotta go. This is your phone, not mine. I'm sorry.
Thank you.
She's very busy.
No, that is very appreciated.
Yeah. She has a lot going on there.
And then Dr. Vincent Fuqua, then you get to have our challenging conspiracy theory question to address. One of the ones that we've heard a lot, are Black people are especially vulnerable to COVID-19 because is the virus specifically targeting Black people?
Okay, yeah, I know that's, it is a very interesting, you know, theory or conspiracy theory that that goes out there. So the virus itself is not specifically designed to attack Black people. So that's the first thing to put out there. But as Dr. Bennett mentioned, is because of our community, we are vulnerable because of the disparity that exists among, you know, our hypertension, you know, heart problems, you know, diabetes and variety, all those things does you know, impact us. So that's why it's important for us to be as careful and as safe as we possibly can. But the virus itself is not specifically designed to attack Black people. I understand the reasoning why we think that and we feel that because of history, because of the way that we have all been, you know, treated, and that's just a matter of fact. And you know, that's just so real of how we've been treated, and so we're very careful, very cautious of thinking like, okay, when the virus comes out, it's just another way of this society's trying to attack and trying to get rid of Black people regarding that aspect of it. But for this particular virus, it specifically is hitting all populations, regardless of what your race is, regarding what your gender is, regardless of what your economic status is, it's hitting everyone. So it is not specifically designed to kill Black people, but we can be vulnerable because of the health disparities that exist among us. And that's the reason why it is very crucial and very important for us to be able to do what we need to do to prevent it as much as possible from coming into our community.
Thank you. The other one that we've heard is, should people be avoiding all Asian people because they're carriers of the virus?
Okay, thank you. Yeah. You know, one of the things that I think happens a lot in our society is the minute that one particular group is named as potentially the cause of something, we immediately go into our mindset saying, okay, because of that, this is the reason why we're getting this. You know, Asian people is the reason why we're actually, you know, getting this virus. Where in reality, it has nothing to do with the fact that they're Asian at all. So regardless of what someone's race is, the thing to keep in mind is Asian does not have it any more than anyone else. And so you can still come in contact with someone who's, you know, who identify as Asian, because it does not mean that they will actually have it. The only ones who have it are people who show symptoms. And if they show symptoms, they should be taken care of and being quarantined or isolated if they actually, you know, have it. So the thing that people have, in my mind, is the stigma that we put on the community. And for us as leaders, it's important for us to find ways to break that stigma. It's very similar to how they put stigma on us as African Americans. Whenever something happens to us, they immediately say we need to avoid Black people, you know, because of this. And that's exactly the same thing was happening with people who identify as Asian. We're stigmatizing them because it was first found in that community. And so therefore, we think because of that, they're all are, infected with it. And we're in reality, they actually not all infected with it at all. So that's why it's important for us to understand the information and understand that it actually affects everyone, and to figure out a way to how to break that stigma, because the truth of the matter is we need to do this all together. And we cannot isolate ourselves from other community because we are afraid that they may because we're afraid that they actually was the cause of it.
Are there other conspiracies that you've heard? And then what advice do you have for us as we continue to face a growing situation?
I can't think of any other conspiracy right offhand, but I do think what we can do, and which I think is really, really important, especially as leaders, especially as faith leaders, is to understand that this is bringing up a lot of stress and a lot of trauma in our communities. It's really, really impacting us in ways that we never even thought possible. To experience the fact that we have to be in shelter in place, that we're not allowed to really hold or give people a hug who we really, really love to embrace when we see them, that impacts our mental state. And to be aware of that as faith leaders of what individuals are going through and how we can go about it, helping to support them, through that. Because that is just, so crucial and so important is our mental state of how this is impacting us. It's not just physical. It is mentally, it's impacting us in more ways than people even realize. And we need to be able to address that as much as we actually possibly can, with regards to that aspect of it. And the other thing is, and I know it's not always easy, if we do see individuals or see our communities doing things that are putting ourselves at risk, is to speak up, regarding that, to not to be, quiet about it. I think it's important for us to be accountable for what we're doing, but also being very accountable to our community, as well, and to, let them know that, in order for us to stop this, we need to do this collectively as a community, not only individually, as everyone. And I think, those are things in my mind that I think is very, very important with regards to that.
For me, the big question is not what the content of the conspiracy theories, but how the African-American church and people who are trusted can be used to dispel those myths. And do you have some ideas about how we can collaborate with the health department and the pastors to be truth sayers or to be people that are trusted? Because I think conspiracy theories run on mistrust.
Right, definitely.
And how can we work together to build the honest message?
Right. Well, one of the things that we're actually doing here now in San Francisco, we're working with an African-American faith-based coalition here in San Francisco. They've been working with us a lot on COVID-19 to be able to give them the information that they need and giving them the resources that they need, so we can partner together regarding that. So that way they can be able to, give it out to their congregation for the individuals who come to their community. And that has been extremely beneficial and extremely helpful to have their partnership with us while we're doing this, because they know their community better than we do. And to be able to have them to be part of it and to help guide us, and also helping to make sure that we actually putting out the correct message in an appropriate way has made a huge difference, regarding that aspect of it. And then there's also this other organization, the Interfaith Council, and they do a webinar once a week also, with, leaders in the Bay Area, about like 800 of them, and giving them also information about COVID-19 and constantly educating them so they can also give it, to their individuals as well. So it really is about partnering with faith-based leaders to ensure that they understand the message and to ensure that we're doing what we're supposed to do as a public health and giving the community the resources that they actually, need, for themselves. For an example is one of the big things that's happening is food distribution. We realize and recognize how many people need food because of what's going on. And so we've been able to work with the faith-based coalition to be able to set up times where we can go and do distribute food to the individuals who are not able to come out of their homes, and be able to set that up and be able to give them resources, regarding that. And that's helping the community to have trust and faith in us, because they're seeing us actually not only talking about it, but actually doing something about it as well. So we're taking action. We're not just, being behind our desk. We're actually going out and doing the services and the resources that they actually need. And I think that's how you slowly build trust and allow them to be able to, believe in the messages that you're actually putting out there, because they are involved and we're showing action by doing.
And on cue, I just want to say Bishop Ernie Jackson has joined us, who is actually the co-chair of the
Perfect timing.
coalition.
Yes, Bishop Jackson, you can take that over. There you go.
So I just wanted to say that, and I know one of the things. And before you talk, Bishop Jackson, because we're running out of time, but I'm interested in the specifics, since Darrell raised the conspiracy, and anybody can jump in on this. What did you do? How do you respond to that? How do you, and how effective is that to do that? To encounter the conspiracy and bring it down? And what is it that you wish the communities like public health and whatever helps to do that?
So I think we focus on what we know, and not exacerbate the unknown and cause more fear and anxiety. I mean, I think people of faith are in the business of quelling mess, not promoting mess. And so I hope that we can do that.
Okay. Well, thank you, Dr. Fuqua. And by the way, if you have any more questions about him or his boss, I will, and you can see it's hard to get a hold of her, but she's very good at explaining things, as you might have noticed. And so we really do want to ask her questions and explain it in a way. I mean, one of the takeaway I got is one of the reasons Black churches are so dangerous because we sing. That do make sense, okay?
That makes a lot of sense.
Nobody ever said that to us. I guess, thank God she's a child of the Black church. That makes sense to us. Okay, the next I want to bring on the next presenter, and this is really important because we keep hearing this. What do you do with the anger? There's a lot of anger out there. About we die, like, again, we're the people that's dying. Again, we can't, grieve. And there is Dr. Peter Goldblum, who really is going to, say that we can take some lessons from the AIDS phenomenon and what happened to the community after, because of something. And he is introduced to me, and I'll bring him on, something that I didn't think about it. We are suffering now what's called stigmatized death, which is, you're dying because of the vulnerability of a community. And for the first time, we knew that, but now we're experiencing that and understand that. I mean, you know it in your head, but now it's like we're dying because we don't have hospitals. And so there's great anger. And if you don't, and what we know about grief, if you don't use anger to move forward, it will actually lash out or hurt you. Dr. Peter Goldblum. And I should say, I didn't give him his introduction. Dr. Peter Goldblum is, in fact, the founder of the UCSF AIDS Health Project, among 20 other organizations he founded that are still going on. Not 20, but at least 4. Go for it, sir.
Thank you. It is a great privilege to be able to speak to you, and I'm filled with memories and feelings, and some of those are my own feelings about being vulnerable to this virus, and some of them are memories from, I just calculated it's now 40-something years ago in the AIDS epidemic. I was working with a group of gay men that had hepatitis. So when the AIDS epidemic hit, they asked me to come on because the transmission of hepatitis and HIV we didn't know how the disease was transmitted, but we kind of felt like hepatitis might be a good model. So they asked me to join the consultation group to design the prevention program for HIV in San Francisco. And there's some similarities in HIV, but I also want to say there are significant differences. And so while I think there may be some lessons to be learned, but there's also some things that you guys will be facing, or we all will be facing in this epidemic that we didn't face before. First cases of AIDS were reported in 1981. The thing I really want to speak to is the idea about HIV and prejudice, or stigma, as Floyd said, stigmatized disease and stigmatized death. And the use of blame and prejudice and discrimination and violence toward people who are considered carriers or people who brought the disease to us. Now, there are differences that the HIV was transmitted through body fluids, blood, semen, vaginal fluids, where COVID is airborne. So COVID is much more contagious than HIV was. And therefore, the restrictions are much more difficult. Well, I guess, the restrictions for AIDS was, in the area often in sexual behavior or in the area of IV drug use. And for some people, those were terribly difficult. I know they were difficult for me, but I don't know, if I had a choice, if I could have sex or hugs at this point in my life, I think I'm going to go for the hugs. But fear breeds prejudice. And I think that what we're seeing is like a case study in what happens when people feel powerless, feel afraid, and that generates prejudice. Now, some of this prejudice may be prejudices that we had kind of put in the background, called latent prejudice, that we thought, we don't believe that about Asian people. We don't believe that about African Americans. We don't believe that about gay folks. But under certain level of stress, these prejudice can come back. I mean, just think about it. You're driving down the road, somebody cuts you off. What's the first thing that comes to your mind? That blah, 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 blah. And you just kind of pull out those racial prejudices and, that old racist deep inside of you, or maybe not so deep inside of you, comes bubbling back up. So these latent prejudices really often ache for a scapegoat. We just look for a scapegoat. And I was so happy that Dr. Fuqua, I probably messed up your name, sorry, talked about the role that the churches can have in terms of reducing prejudice and scapegoating, not only of our own people, but of others. I just want to say a little bit about messaging that we learned from the HIV public health messaging. One is that public health messages must be clear, consistent, fact, science-based to be trustworthy. And I think, perhaps the indoctrination of working with these great folks at the Project Trust for 3 years now, but it's really important that the messenger be trustworthy. And that's where I think that the churches and when we're talking about working in the African American community, those trust agents within those communities really need to step up and dispel myths and provide factual information and provide avenues for help where possible. And some communities, like the gay community, like the African American community, have had histories of the government not being trustworthy. And so in those cases, we have to have special outreach to those communities from within the community. That was, I think, the most powerful thing about the AIDS epidemic, is that the institutions, the Shanti Project that worked with people, giving buddies to people with HIV, or the Project Inform, which helped people who were longing for medical help. And there were a bunch of different medicines out there, a lot of different kinds of experimental drugs, and to say which, they helped people make those kinds of decisions. And those came from the community. And that's really important. And people who are resisting those kind of messages may need special help from within the community to understand and listen and help. Motivational interviewing, and that's a technique where you help those people who are not motivated to change, even though they're resistant. And its basis is listening and being non-directive, and understanding that there are reasons why there are people who are resistant, and that rather than just try to barrel through, you have to help them. For me, and this is where I'll wrap up, for me, and to answer Floyd's question, how did I deal with the rage that I felt, the rage of losing almost half of my friends, the rage of the government not caring, at least in the early parts, and not stepping up. One was participating in my community, to work with the community to help other people. It's just part of my personality. When I can help other people, I feel less vulnerable. And two is to participate in community activity like Act Up for Us, where we're pressuring the government to take the right action, to do the right thing. And I want to just close by saying the models that we used and all of those things, all of those political models, were derived from the early civil rights movement. The community organization models, the protests, all of those things, that script, that playbook was designed in the African American community. And I'm just honored now to be able to do whatever I can to help your community use those things that intuitively and in your bones, and to encourage you to reinstate that effort to protect and save your community and our community. I'm talking like this is one big difference is that COVID is a much more equal opportunity virus, but in this particular case, in this conversation, looking to assist the African American churches and people like Ernie, Bishop Ernie and Floyd and Bishop Janice, and all of you who are working so hard to better your community, and I applaud you.
The moment when their community was attacked the most became the moment that the greatest moment of opportunity to organize and really move forward. And this moment of anger and of death, we don't redeem the moment, but we can certainly do the same thing. Healthcare, you can talk about it for years. Now people get it. Why and the real reason for healthcare. And also health issues. Both of you on Sister Eloise and all of the folks that are on this call, y'all have been the forefront of healthcare. Nobody really was excited about it. Now, when you hear the doctor says bad health puts you at more risk, this could be the moment that you can create coalitions around that. And the idea is how to take some of the pain and anger and turn it into what Peter says, another civil rights moment. Because what's happening with the African American community is not a medical issue. We should not be more vulnerable. It is a medical issue because we've been neglected. This is what the CDC is saying. It's medical neglect, it's inequalities showing up in a disease. But it isn't just that we were physically in something wrong with us. And so it's really important to think about that.
So as we close, Floyd, incredible resources and all of the presenters. I just want to put forth a couple of thoughts that I'm sure will be expanded upon in later formats. You know, I was listening to the National Domestic Violence Hotline, and it was talking about the spike and the increase in domestic violence. It is also those of us who are child abuse prevention professionals and work in that area are clearly concerned about the spike in child abuse and neglect that's going on while families are sheltering at home. And it's even more so because we know that mandatory reporters are not seeing the children every day, and therefore we don't know what's going on right now for our nation's children. And so we are preparing as COVID-19 spikes. There will be spikes in domestic violence and child abuse. And so I want to just put that out there into the atmosphere as we pray for our children and our families. We can make phone calls to families and try to help kind of deflate some of the anxiety and pressures that they're experiencing at home. So telecounseling, right? We do telemedicine, telecounseling. And then lastly, you know, as Floyd and Kathy knows, much of my personal background has been in the area of experiences with child abuse and neglect. And so the whole ACEs framework that I'm sure Dr. Brown and Dr. Goldblum is familiar with, and many others of you, the notion that if we don't deal with our stuff is going to deal with us. But what COVID-19 is going to be a bona fide ACE. It's going to be a bona fide adverse childhood experience. And kids will grow up in 15 years remembering the trauma around the COVID-19, just as many of us remember any other national tragedy. And so I just want to raise the ACEs framework and not stay there, but also talk about it in the context of hope and resilience. What are resilience scores as we also talk about adversity scores?
We did not ask you because we thought it's something you may not be interested in. So I'm not gonna put you on the spot, but in our conference there is a track called Unintended Consequences. One of the groups called and that is exactly that, and I forgot the other thing. And what's happening with children who are special needs in schools. That whole child unintended consequences. So now we'll come back to you and formally ask you to maybe lead that particular track and concentration of mental health professionals and pastors and public health people sitting down working that out at the conference.
Let's not forget spousal abuse also.
Right, absolutely. And anyway, yes, anyone else? It's funny how these things just fold in. We wanted to be concentrated in this conversation on death and dying, but that came out. I think we had 8 areas, and that's one of the 8 areas that showed up. Yes.
Floyd, the other thing I want us to really kind of look at, and if not for the conference afterwards, would be the whole discussion that we have been having around mental health issues.
Yes.
And how people are going to be dealing with this, because there are not going to be a lot of available, affordable services in our communities. And so how are we going to work toward providing the supports, the pastoral supports that are needed without becoming counselors on a full-time basis?
Amen to that. That's right. We don't want to get. And one of the things that we don't on the conference, but all of you can think about. Again, this is not on the webinar probably, but there's very little money going out to do any of these issues in the Black church. We have been working hard to do that. And a lot of it is that people don't get who you are and what you're doing. And a part of why we're taking this little time is to remind people you're going to be the #1 referral people. So we need to make sure that we train and involve you. Any other questions, comments, ideas, insinuations, or accusations that you want to make before we leave? It's the way I end all my church meetings, so I'll end it this way as such. And if you want to make an insinuation, accusation, I usually say, pray about that and see you tomorrow. All right. God bless you and thank you. Shalom. Thank you, sir. Thank you, ma'am. Bye-bye.
Thank you all.
All right, thank you.
Thank you.
Way